This is Dr. Eric Parsons. I am a family physician at Health Point in Kent, Washington. I have done community health center primary care for my entire career, and I also mentor and teach medical students at our site. I am the Regional Director of Medical Education and Associate Clinical Professor at A.T. Still University, School of Osteopathic Medicine, Arizona, at the Health Point campus in Renton, Washington. I am also an adjunct clinical faculty for the University of Washington School of Medicine in Seattle. The GE National Medical Foundation Primary Care Leadership Program has provided community health centers like ours an opportunity to work in a win-win fashion with PCLP scholars from all over the country. We win by gaining the enthusiasm and time of young learners willing to jump in and kickstart projects to help us assess our tools and systems. The scholars benefit from an early introduction into the world of community health centers, the front lines of primary care for our most diverse and needy populations. A community health center like ours is serving tens of thousands of patients at 10 different sites. We have learned to evolve ways to set up systems to track patient populations and chronic disease groups in order to understand the value that our individual efforts and group efforts bring to our community of patients as a whole. This helps each provider go beyond delivering excellent service to one patient at a time. However, we don't always take the time to assess how well we use these tools, such as the electronic health record, the patient portal, telemedicine, and group visits. This summer, our community health center colleagues here and across the country hosted some terrifically talented PCLP scholars who have started the ball rolling for us. As you can see from these presentations, we will begin to have the data and feedback needed to support the systems that work and improve or eliminate those that are not effective. Thank you to the GE, NMF, PCLP scholars, staff, and volunteers.
Hello, my name is Michael Krause, and I am an M2 at the Virginia Commonwealth University School of Medicine in Richmond, Virginia. Over the summer, I was placed at Health Point Community Health Centers in Seattle, Washington. My project involved Health Point's patient portal. The patient portal is a web-based application which allows patients access to portions of their electronic medical records, including their lab results, treatment plan, and referrals. Patients can also schedule appointments, request prescription refills, and send messages to their providers over the portal. As this is an emerging technology which requires a lot of patients, including literacy, health literacy, access to the internet, and access to a computer, certain groups of patients might not benefit equally from its use. Therefore, I wanted to conduct a qualitative analysis of registration in which patients were given a dummy password, enrollment in which patients changed the password and logged into the portal, and used the portal as measured by sending at least one message to their providers. To provide HealthPoint an idea of how its patients wanted to use the portal it was providing to them, I also wanted to conduct a qualitative analysis of messages by reading and categorizing 600 or so messages that the patients had sent. To do this, I was able to extract message content and patient demographic data, including sex, age, race, financial class, and income from HealthPoint's electronic medical record and patient portal databases for every patient 18 years or older with at least one physician visit between 2012 and 2014. My key findings are the following. 19.3% of the target population were registered. Patients 65 and older tended not to be registered, as were males, non-whites, and the self-insured. 73.7% of those registered actually enrolled. Females enrolled more than males. Whites actually bore the second least percentage of enrollees, Hispanics enrolled the least. The self-insured and those with other public insurances tended not to enroll. 22.8% of enrollees sent at least one message to their physician via the portal. There are no differences based on sex. Patients tended to be older than 65 years old, which is interesting because those patients tend not to be registered. Non-whites and those with Medicaid and the self-insured tended not to send messages. Patients conveyed information regarding their medication management, symptoms, referral requests, and lab results the most, and the numbers in the parentheses are the number of messages that were counted. My recommendations are the following. Open bulk registration to avoid biases in registration. Bulk registration is a process in which for every patient who has an email address, they are sent a dummy password. HealthPoint could also open its electronic medical record and patient portal to the 3 other languages that NextGen offers, including Spanish and 2 dialects of Chinese, to avoid language barriers and increase its use. And that can be seen in result 1, in which non-whites tend not to be registered, and in result 3, in which non-whites tend not to send messages. Most importantly, training physicians adequately and providing them with a knowledge of how to use the portal is critical so that they can educate patients on its capabilities. An example of this is encouraging patients to communicate medication management via the portal, as they already want to do. Thank you very much for your time. Bye.
Hello, my name is Ashok Patel from the Florida State University College of Medicine, and this summer I was working with Spring Branch Community Health Center in Houston, Texas. My project was increasing PCMH compliance via EMR. The goal of these 6 weeks was to utilize Spring Branch's electronic medical record system, which was eClinicalWorks, to help them meet the standards set by the Joint Commission to make the clinic a primary care medical home. The Joint Commission is a nonprofit organization that is recognized by many states for medical licensure and Medicaid and Medicare reimbursement. I tackled this problem in 4 different ways. The first was documentation of chronic disease management. This is basically when a patient comes in and they have a chronic condition, sometimes it doesn't get documented as a chronic condition in the EMR. So what I did was found out how to make it so that all these chronic conditions would automatically populate the chronic conditions problem list in the EMR. This saves the provider a few clicks, and it doesn't matter if they remember to do it or not, it's just automatic. Next was tracking of diagnostic imaging. A lot of patients get diagnostic imaging orders, but then they won't get them filled. So the clinic has no way of tracking who has filled them and who has not. And this is important because we don't know why the patient isn't filling those orders. Maybe it's too expensive, or maybe they think they don't need it, or maybe they just weren't educated on the importance of it. So to provide providers with a list of patients who have not filled their diagnostic imaging orders, I created a report that would be sent to the site supervisors on a monthly basis that says, hey, here's the patient, here are all the patients that have outstanding orders that are older than 30 days. So then the site supervisors and the providers can decide who they want to follow up with. Next was preventative health alerts. This is great for things like colorectal screening. Colorectal screening needs to be done once every 10 years, once a patient is over the age of 50. So as of right now, eClinicalWorks doesn't automatically flag patients to require colorectal screening. So I figured out a way to incorporate some alerts that'll do colorectal screening, pap smears, and then later on this could be even expanded to flu shots and immunizations and things like that. Finally, there's the reporting tool. Reports right now are not really easy to create in eClinicalWorks. Only the most simplest reports can be done by end users. And for any sort of demographic information or workflow metrics, you need something a little bit more advanced. There are about half a dozen reports that I specified, and the goal is that the clinic, once funds become available, can contract eClinicalWorks directly, saying, hey, here are the documents, here are all of our specifications, and this is what we need to be done. This lets me contribute, and it also allows a clinic to go ahead with their investment in this opportunity once funds are available. Let's talk about key findings and expected outcomes. As of now, I think we're okay, but I know that in another year they're already going to be opening another site, and then in the future, if they continue to expand, this no longer will meet their needs. If the clinic decides to invest in the reports, it would help reduce wasted man hours and improve patient tracking. I see this every day when I was at the clinic, where one user would be spending hours and hours to meet UDS reporting requirements, which was very cumbersome and should be automated and be made much easier by using eClinicWorks. As of now, I recommend a requirements analysis. Many vendors of electronic medical record systems, they are willing to come out to your site, watch your workflow, and then see how you're doing things and recommend where they can improve, whether it be paid services or just better utilization of already bought services. That's usually very helpful for small clinics like this because they don't have someone on staff who is the tech person or the system administrator. Next, I would say at least a half FTE, a full-time equivalent, should be allocated to someone so that they can be in charge of managing all these workflow issues and EMR issues. Finally, somebody has to have Report Studio training. If we want to do advanced reporting and get advanced metrics and make use of all the full scope of reporting tools that are available in eClinicalWorks, somebody has to get Report Studio training. Thank you.
Hi, my name is Sarah Muhammad Ali, and I'm a second-year student at Howard University College of Medicine. This summer, I was at Atalanta Healthcare in Phoenix, Arizona, and my project basically looked at why patients were not using the online system that the clinic had. So the online system is a way for patients to set up appointments with the doctor's office to be able to request medications and look at their records and stuff like that. And there is a system right now that Atalanta has, but it was not being used. So the objective was to explore why this system was not being used, and I did that via a survey that was conducted at 2 locations in Surprise and Gila Bend. So I had about 53 patients that completed the survey, and I had more than that, but I had to throw away some because they were invalid. So I ended up with 53, and I asked patients to rank which features they would enjoy the most or which features would be the most useful to have on the system if they're not currently using it. So the key findings were that 53% of the patients said that the ability to send and receive secure messages from the provider to and from the provider was the most important feature. So that's huge. More than half want to be able to have that feature, which is not currently offered on the system. Additionally, 20% of the patients would like to have the ability to request medication renewal, which is also not a feature that's currently being offered. And then one of the other features that also got a lot of interest was the ability to request personal health records. So that, even though it was not ranked number 1 at all times, it was consistently in the top 3 features by 43% of the patients. So my recommendations basically go off of that, which is to add those 3 features as part of the system to incentivize patients to use it. And then I would also recommend that patients sign up for the system so they make a username and password directly during the office visit, because as it stands right now, that's not really an option. The patients have to do it from home, and often they don't sign up. So to enhance the use of the system, they should have online tutorials to guide patients on how to use it, and just have the patients sign up directly during the office visit. Last but not least, I recommend that providers become advocate for the system. So just as they advocate the patients to call the office when they have any questions, they could start advocating patients to shoot them a message through the system, or ask them anything they want to request to renew medications, etc. through the system, and that would also incentivize patients to use it and take charge of their own health that way. Thank you, and I hope you enjoyed the talk.
Hello, my name is Alejandro Cha. I'm a rising second-year medical student at the David Geffen School of Medicine at UCLA. My site placement for the summer was Ultimate Health Services Corporation in Los Angeles, California. The title of my project is Patient Perspectives on a Bilingual Online Patient Portal in a Predominantly Spanish-Speaking Safety Net Population. The objective of my study is to assess the attitudes of patients serviced by a large safety net provider on the benefits and drawbacks to a bilingual English-Spanish patient portal. The methods are, in conjunction with the implementation of an online patient portal in June 2014, primary care patients completed a 37-item survey administered during a face-to-face interview. This survey was conducted during June and July 2014 at Ultimate Medical Group in Commerce, California. Survey demands included computer internet access and literacy, barriers and facilitators to patient portal adoption, and portal preferences. Patients were eligible if they were 18 years of age or older and were fluent in English or Spanish. Of all eligible patients approached 488, 400 agreed to participate, a 82 response rate. My key findings were the majority of patients had computer access, 65.8%, internet access, 78.3%, a current email account, 66%, and a smartphone, 70.5%. However, a digital divide exists, with patients over the age of 40, Spanish-speaking, with a high school education or less, and an annual family income of less than $10,000, having significantly less technology access. My recommendations for Ultimate are, because more patients have access to smartphone, 71.17%, than computer laptops, 64.86%, Ultimate should pursue a mobile version of My Ultimate, as the majority of patients, 82.43%, believe it would be useful, with 77.48% reporting being interested or very interested in using it. Ultimate should also continue with full rollout of My Ultimate features, as patients reported wanting to utilize various portal functionalities. 92.3% communication with provider, 93.7% request copy of health record, 98.2% schedule appointments. And finally, Ultimate should increase My Ultimate visibility through different marketing strategies aimed to familiarize patients with the various benefits associated with patient portal use. Thank you.
Hello, my name is Anita Patel, and I'm currently a second-year medical student at Northwestern University. This summer, I focused on a project that explored the barriers and facilitators to the effective use of electronic health records at Jackson Hines Comprehensive Health Center in Jackson, Mississippi. The objective of this project was twofold. First, to determine barriers to effectively closing notes in the electronic health record by healthcare providers at Jackson Hines Comprehensive Health Center, a federally qualified health center in Jackson, Mississippi, and secondly, to implement an intervention that facilitates the effective use of electronic health records using the Deming model of quality improvement, which is also more commonly known as the Plan, Do, Study, Act model. The approach I took to addressing these two objectives was to first conduct 9 semi-structured, focused interviews of physicians and nurse practitioners to assess their perceived barriers and facilitators to using the electronic health record, eClinicalWorks. Providers interviewed represented the 4 clinical departments at Jackson Hines, namely family medicine, adult medicine, pediatrics, and obstetrics gynecology. After generating a list of possible barriers and facilitators from the interview transcripts, a measurable facilitator, namely additional administrative time, was selected by clinical leadership as a feasible intervention to implement. Thus, 1 hour of administrative time was provided daily over a 3-day period to a provider to close notes. The effectiveness of this small-scale intervention was then assessed using the Deming model of quality improvement. Our outcomes were that productivity, as measured by the ability to close notes, increased by 11.9% over a 3-day period, which was more than double projected increase of 5%. Thus, recommendations were that 1, we continue with the domain model by interviewing the provider that received the intervention to determine her perception of its effectiveness and the barriers and facilitators at this level of intervention. And then to modify accordingly and scale up the intervention to include all of the providers as appropriate. Thank you.
My name is Philip Ramirez. I'm a second-year medical student from the University of North Carolina at Chapel Hill. My site placement was Central Med in San Antonio, Texas, and my project was called Teledermatology: Fleshing Out the Benefits. The objective of this study was to assess the applicability of telehealth services at Central Med. The way I did this was by utilizing a store and forward telehealth dermatological practice guide as a probe for the financial and temporal implications of the implementation of telehealth at Central Med. What this study found was that Central Med could actually save money, almost $70,000 per year, while granting almost 2 times the amount of patients access to dermatologic care. This would, however, require additional administrative hours, which would total around 40 hours, 2 40-hour work weeks per year. Furthermore, dermatologists would be able to, on average, see 3 patients in the amount of time that it would take for them to see 1 with a normal in-clinic visit by using the store and forward telehealth dermatologic practices. So with these findings, the recommendations going forward are to be cautiously optimistic about these findings because the probe was very superficial, didn't take into account a lot of the specificities of the implementation of a new medical practice. So the beneficial aspects of telehealth shown by the store and forward telehealth methods should be used as a platform to garner interest in further more in-depth studies of telehealth applications at Central Med. It is my hopes that Central Med will implement new projects exploring telehealth, not necessarily just teledermatology, so that they can help benefit the constituents of their practice.
My name is Ayana Worthy, and I am a second-year medical student at the University of Illinois at Chicago College of Medicine. I had the distinct pleasure of participating in the GE-NMF Primary Care Leadership Program at Central Mississippi Health Services, located in Jackson, Mississippi. My independent service learning project has been a report on the progress of CMHS Southwest Clinic's implementation and compliance with patient-centered medical home standards as dictated by the National Committee for Quality Improvement. My project is accompanied by recommendations for further progress Level 3 National Committee for Quality Assurance patient-centered medical home recognition by the deadline of October 31st, 2014. The patient-centered medical home is a more than 40-year-old concept that has found new life amidst the challenges of modern healthcare delivery. Central Mississippi Health Services Incorporated Southwest Clinic has been a part of the Federal Tax Relief and Healthcare Act Medical Home Demonstration Project since 2000, which gave select practices in 8 states 3 years to achieve NCQA patient-centered medical home recognition. In 2011, the NCQA dictated 6 standards that define the patient-centered medical home. They are to enhance access and continuity, identify and manage patient populations, plan and manage care, provide self-care and community support, track and coordinate care, measure and improve performance. According to the NCQA, 6 must-pass elements are considered essential to the patient-centered medical home and required for practices at all recognition levels. These 6 must-have standards are access during office hours, using data for population management, care management, support for self-care processes, tracking referrals and follow-up, and implementing continuous quality improvement. The goal for my project was to assist Dr. Frank McCune with implementing the patient-centered model at the Southwest Clinic site of Central Mississippi Health Services. The primary goal for my time in Jackson was to write a body of protocols and procedures that would incorporate the medical home model into the day-to-day operation of the clinic. These protocols were to cover the 6 must-have features of the medical home as defined by the National Committee for Quality Assurance.